My name is Gabby, and I work at Shatterproof. We are a nonprofit committed to addressing the addiction crisis in the United States. And my team and I have a specific focus on stigma reduction, and that's what we're going to talk about more today. So first, Shatterproof parcels off stigma into 4 different buckets. You can see 3 here on the slide, but we'll go through all 4. The first is public stigma. So here we're talking about society's negative attitudes towards a group of people that can create an environment where those people feel unwelcome, judged, or blamed. And another part of public stigma is called stigma towards MOUD, or medications for opioid use disorder. And this is really the idea that some forms of treatment and recovery are deemed as more acceptable than others, and some might carry more stigma. So that falls within public stigma, but is something that we highlight separately. And then we also have structural stigma. So here we're talking about systems level discrimination, and that can be caused either by institutional policies, so things that are codified and written down, for example, maybe something you'd find in an employee handbook, or it can be dominant cultural norms. So really following the status quo, things that aren't written down, but maybe relayed or assumed as part of that structural system. And then both public and structural stigma can interact and affect self-stigma. And here, this is where an individual accepts societal stereotypes and they experience a reduction in self-efficacy and self-esteem, which is really important to address when we're talking about recovery, because both self-esteem and self-efficacy are vital there if we want to talk about that path. But overall, no matter what bucket it falls in, stigma manifests as discrimination. It can affect and dictate how policies are created and if they're created, how healthcare can be provided and if it can be accessed, as well as with treatment. And it can lead to deep feelings of exclusion and shame for people with substance use disorder and can lead to negative health outcomes. A little bit more here on stigma and healthcare. While we're going to get into some individual level change that you can all make today as providers, we do like to highlight that the system is not currently designed to support individuals with SUD or the providers that care for them. While in the last decade or so, we've really seen some great strides in this area, there is a lot more that needs to be done. However, we're going to talk about this individual level change because while we're waiting for that change to catch up on a system level, we do know that attitudes towards individuals with SUDs tend to decline during residency training and can negatively affect patient care. And then we also want to highlight that access to treatment and care is even more challenging for birthing people and mothers, yet focusing on them and their babies is vital to healing and the health and long-term stability of all people, children, family units, and the community at large. But one silver lining that we do know is that attitudes towards individuals with substance use disorders can be improved even after taking one online training module. That's something we've done at Shatterproof and continue to do, and it shows us that there is a way forward. More specifically here on stigma and reproductive health. So because at Shatterproof, we talk a lot about language, we want to practice what we preach. So you might hear me use the term birthing people and women, but we pulled these stats from a couple different places and now mainly focus on the term woman. So according to the Women's Brain Project, 10% of pregnant women and 13% of women who have just given birth struggle with mental health disorders. So this is much wider than substance use disorder, but is important to note. NIDA estimates that about 5% of pregnant women use one or more addictive substances. Both mental health and substance use disorders are considered risk factors for facing stigma in the healthcare setting. And this is in addition to other individual identifiers that can compound these risk factors, including gender, race, appearance, and any other identifier. And lastly, without taking care of mothers and birthing people as they address their own substance use, we are running the risk of furthering the addiction crisis for generations to come. So an example of why, again, we're going to talk about this individual level change in language, and that's because we know words shape how we view people and how we treat them. So as an example, there was a study done with over 500 clinicians that were randomized into 2 groups. One group was asked to refer to their patient as an individual with a substance use disorder. So here we are using person first language. We are highlighting first and foremost that that person is an individual. We are mentioning and bringing them into relation with their substance use. However, it is in a medical or a more medical reference, so substance use disorder. And then the second group was asked to refer to their patient as a substance abuser. Excuse me. As a substance abuser. So here we're taking out that person first language and only focusing on that individual in relation to their substance use and specifically with that term abuser. And it was found that clinicians who used the term substance abuser were more likely to say that their patient was personally responsible for their illness and to support punitive action over treatment. So, again, another reminder of the importance of language that we use verbally, that we put in patients' charts, can really affect their health outcomes. To address this, Shatterproof and many similar organizations have created language guides. So you can see some examples here on the screen of that, and it should be linked later on in the deck. But just to go over this, looking at that last example, the terms dirty and clean are generally terms that we might hear, but can carry stigma. So instead, using phrases like a person who tests positive or negative for substance use or a test that comes back positive or negative can be really helpful in decreasing stigma. And in that last column, you'll see a rationale. So dirty and clean, as we know, are associated with filth as opposed to a medical condition, which is where we'd more want to be aligned, and can invoke punitive bias and shame. So again, trying to focus our language on something that's less stigmatizing can be really helpful when we're working with our patients and trying to reduce stigma. And then this slide is just a reminder about how and why we're changing language to improve care. So, as the general public and healthcare professionals, we might hear people who have a substance use disorder talk about themselves or people in their community using terms that we've talked about as being stigmatizing. However, we don't want to make it our job to ask them to change their language. We want to be mindful of using less stigmatizing language in order to improve health outcomes, but we also want to ensure that the spaces that we're occupying are making our patients feel safe and heard and like they can share with us. We don't want to be asking them to change our language, but do want to be mindful of our own. And a quick review for what we can do. Again, adjusting our language is a really big step here as we wait for that systematic level change. Learning the facts, so attending webinars like these are a great way to do so. We also want to make sure that we acknowledge how this work can support our families, friends, and larger community. Because of that stigma we talked about early on, we never know what someone might be carrying and what they might be dealing with in terms of substance use disorder. And this work not only allows us to see the whole person professionally, but also at large. We also want to be mindful that we're listening to people when they're sharing their stories with us. So this is both verbally, maybe repeating back to them what we've heard or making sure we're asking thorough questions, but also physically. Are we standing further away than we might otherwise stand? Are our arms crossed? Do we look like we don't have time for this? Like, how are we coming across physically? So that's something that is also important to consider, that we've heard anecdotally from people that we work with that they notice in a healthcare setting. And then lastly, speaking out when we hear something stigmatizing and being sure to challenge misconceptions and stereotypes as they come up. This does not always have to be something confrontational. It can be as simple as if someone comes to you and says, "Oh, this test came back dirty." You can say, "Oh, it came back positive for X substance. Thanks so much for letting me know." And just exemplifying that language change in our everyday work can really make a difference. And then lastly, we want to highlight the work that Shatterproof is doing across the state of Pennsylvania. We have state campaigns across the country, and the Pennsylvania campaign is called Life Unites Us. And on this slide, you'll see an example of the story library associated with that campaign. This library gives a platform to Pennsylvania residents that are affected by the addiction epidemic and highlights a need to replace stigma with support and understanding. If you go to this link, you'll see that we have a multitude of stories shared from people who have direct lived experience, have family members with lived experience. And then we also have EMTs, healthcare professionals, and other caretakers that share their stories too. If you are interested in sharing your story, you can reach out to me at my email. We're always looking to take new submissions and update the website, and we'll be happy to have you.